Lichenoid drug eruptions is a very important topic both from practical as well as theory point of view. We are going to discuss this topic. Watch it till the end. Hello dear students, myself Dr. Maddineni Srinivas. Welcome back to my YouTube channel. So this was a theory question in the DNB exam 2025. So only lichenoid drug eruption, this was given as a 6 marks question. So let us see this from all these sources. So what is this lichenoid drug eruptions? It is also called as the drug-induced lichen planus. So though it is drug-induced lichen planus, but there are many differences between the classical lichen planus and drug-induced lichen planus. We are going to see all those important differences in this particular video. So remember dear students, it can be initiated by administration of systemic medications, and also some chemicals exposure could also cause, and also contact allergens could also trigger this condition. So what is that important etiopathogenetic cascade which you have to remember, the cytotoxic cascade? We are going to see that. So the development of the drug eruptions is driven by drug altered cell mediated immune response targeting especially the epidermal basal cell layer. Not only the basal cell layer, the other layers are also going to be affected. How they are going to be affected? What is the reason? So this we are going to see in this flow chart. So the basic problem is the systemic drug intake. It is going to cause the accumulation of the drug in the epidermis, and that drug molecule is going to be very small. It is going to act as a hapten. What is a hapten? It is an incomplete immunogenic particle. If it combines with other proteins covalently, if it bonds, then it is going to form a complete antigen, and it is going to bind to the keratinocytes in the stratum basal layer, after which they are going to become altered self antigens, and they are going to activate the antigen presenting cells, which are the Langerhans cells and the dendritic cells. So then what happens? There is going to be a recruitment of the CD8 positive cytotoxic T lymphocytes, CTLs, which are going to ultimately cause the release of the perforin, the granzyme, which is ultimately going to cause the vacuolar basal cell degeneration, and also the colloid civate body, cytoid body production. So this is what is happening basically. So in the drug-induced lichen planus, so what can we see? There is going to be the high frequency of CD8 plus T cells and enhanced perforin expression if you take a biopsy. So this is understood because the pathogenesis is clearly because of the CTLs. And also depending upon the class, so there are so many drug molecules which can produce this drug-induced lichen planus. So the just a trailer we can say NSAIDs, beta blockers, TNF alpha inhibitors, and also checkpoint inhibitors. So these are all the triggers. So we are going to see in detail what are all the medications and what are the classical points related to each of the class. And you must remember that thiol group is very characteristically associated with the drug-induced lichen planus, LDE. We will call it as LDE. So cardiovascular and antihypertensive medications, beta blockers, ACE inhibitors, and also the calcium channel blockers, these could be associated with LDE. And remember the captopril, it is classically associated with LD because of the thiol group which is present, and also amlodipine, which is the calcium channel blocker, it is associated with the elderly individuals who are hypertensive. So these are the antihypertensive medications which are used, and the diuretics, the hydrochlorothiazide and furosemide. And it was observed that patients having the LD classically were having the lesions in the photo-distributed areas, that is over the face and the V area and also the dorsum of the hands. Antimalarials, you all know what are the antimalarials, and the classical point to remember is antimalarials producing the lichenoid drug eruptions, the lesions clinically are more of psoriasiform morphology, that is they are having the scaling present over the lesions. Very important point to remember. So this is a patient having the LDE which is having psoriasiform morphology, that is presence of the scaling because of the antimalarial usage. Antimicrobials, these are all the antimicrobials, but out of which griseofulvin is routinely used in the tinea capitis in dermatology. It is also associated with the lichenoid drug eruption over the photo exposed areas, especially as you can see in the dorsum of the hands, right. Next we have this rheumatological anti-gout medications, the gold salts and D-penicillamine and allopurinol. So gold induced LDE is very classical, and it is going to be very severe because of the intense epidermal cell death which can occur in this condition, right. Next is antineoplastics, biologics. These medications are used in the cancer chemotherapy. So, anti-PD-1, nivolumab, pembrolizumab, imatinib, hydroxyurea, TNF-alpha inhibitors. And these could be associated, this imatinib especially, it could be associated with secondary palmoplantar hyperkeratosis. Okay. So, now let us look at what will be the differences between the classical lichen planus when compared to the drug-induced lichen planus, Lichenoid Drug Eruptions. So, there are some very important differences which you must know. The age of onset is going to be 50 years in the case of the idiopathic lichen planus, whereas it is going to be little bit elderly. So, the mean age of onset in the case of idiopathic lichen planus is 50 years, whereas in the drug eruptions, that is drug-induced lichen planus, it is going to be more age, that is 65 years around. Okay, and probably it could be because of the elderly patients, they are going to have a polypharmacy, multiple medications are going to be utilized. They could be having this hypertension. Okay, because of the multiple drug usage, there is a likelihood of the lichenoid drug eruptions is high in the higher age group. And also the onset is spontaneous and it is not related to any medication. So, we cannot say any latency, but here in the drug induced lichen planus, extremely long latency period could be observed, that is after the medication is started, from months to over a year there could be a latent period without any drug rash, but you have to have a high index of suspicion if the medications which we have discussed already, if the patient is taking them and if the patient is developing the highly itchy lesions clinically, then you must have high index of suspicion. Think of LD, it could be ranging from 2 to 3 months as a median latency period. And the distribution, so these are some of the very important differences from now on which we are going to discuss from the classical lichen planus to drug-induced lichen planus. So, the classic sites are going to be affected, having the lesions in the classical lichen planus, flexural areas on the wrist, forearms, dorsum of the hands, ankles, shins, presacral area and genitalia. Whereas in the drug-induced lichen planus, the involvement will be symmetric, it is going to be generalized, but it is going to classically, very interestingly, spare the classic sites of the classic lichen planus. So, that is one very important point to remember. It is going to affect mainly the trunk and the extremities, right. Not only that, the lesion morphology is also going to be very different. If you remember in the classic lichen planus, you all know so many peaks are there, proretic papules, purple colored plaques, which are going to be plain topped. So, this is a classic description, whereas in the drug-induced lichen planus, the morphology is going to be very different. It could be polymorphic, that is patients can present with eczematous lesions over the body. There could be psoriasiform lesions. If you remember, we have already discussed psoriasiform in which medication it was associated, anti-malarials common. Pityriasis rosea like lesions can also be present. So, when these lesions, especially pityriasis rosea, psoriasis, usually they are not associated with itching, not much itching will be there in the patients, but if the patient is presenting with lot of pruritus with psoriasiform morphology of lesions after initiation of the drugs, okay, that is why history of medications is very important whenever you are taking the drug history. Okay, and also pityriasis rosea like lesions, usually pityriasis rosea is not having any pruritus, it is asymptomatic, but if patient is having symptoms, then think of possibility of Lichenoid drug eruptions. And also you will usually see in the lichen planus patient, there is going to be this lacy network pattern of Wickham's ray present over the body, which is very classic, but it is going to be absent in drug-induced lichen planus. Not only that, mucosa nail involvement is very common in the classic lichen planus, and it is going to be very peculiarly absent in the case of the drug-induced lichen planus. One question for all of you, in the nail, what is the pathognomonic nail change which can be seen in the patients of classic lichen planus? If you know the answer, please put it in the comment section. Next is photosensitivity. We know it is unusual except for the actinic lichen planus variant, but in drug-induced lichen planus, we have already seen the medications, the anti-malarials and also the griseofulvin are having photo-exposed sites having lichen planus like lesions, right. And also the healing in the classic lichen planus will leave behind moderate hyperpigmentation, whereas if it is drug-induced lichen planus, the pigmentation is going to be very dense, intense, and it's going to be highly persistent, very difficult to treat, irritating, post-inflammatory hyperpigmentation. Resolution results over a period of months to even 2 years, whereas here in the drug induced it's going to be a very delayed resolution which can be seen. Even after the stoppage of the culprit drug, the patients may be having the lesions and may also develop new lesions also because of the immunological memory of this to these drugs. So, this is one very important point which you have to remember while counseling the patients, that if we identify the drug, if we stop the medication also, there is a likelihood that the patient may be having the lesions persisting for quite a long period of time. So, this is very irritating both for the patient as well as for the treating dermatologist. And so, how can you identify the differences between, what are the differences between histopathology of classic lichen planus and the drug-induced lichen planus? So, very important differences are there. In both of them, we are going to see the interface dermatitis, that is band-like lymphocytic infiltrate will be there in both of them, but the other points which are going to be discussed, they are very important to differentiate both of them. So, that is in the stratum corneum and also stratum granulosum, we are going to see the orthokeratosis, which is hyperkeratosis without any parakeratosis in the classic lichen planus, and also there will be thickening of the stratum granulosum, which is wedge shaped hypergranulosis. In drug induced lichen planus, we are going to see the parakeratosis, that is persistence of the nucleus in the stratum corneum can be seen, very peculiar, and this could be the reason for the clinical morphology of psoriasiform lesions also being present in the drug induced lichen planus, which we have already discussed in the previous slide. Focal parakeratosis, and also the disruption is not limited only to the stratum basal layer, the disruption can go up to the granulosum layer, leading to the thinning of the stratum granulosum layer in the drug-induced lichen planus. Okay, this is also very important point. So, basal cell liquefactive degeneration and also severe bodies are seen in the classic lichen planus. They are going to be seen even in the drug-induced lichen planus, but here the destruction is going to be, damage is going to be very severe. So, extensive necrosis of the individual keratinocytes can be seen extending up to spinous and granular layers. That is the reason why there could be this thinning of the granular layer. The cytoid bodies usually are seen in the lower epidermis in the classic lichen planus, but here we can also see in the stratum corneum level also. So, that much extensive the damage could be in the drug-induced lichen planus. So, here band-like lymphocytic infiltrate will be seen, very classical, but in the drug-induced lichen planus, very interestingly, there will be presence of the eosinophils and also plasma cells in along with the lymphocytic infiltrate. Important point again to differentiate between these two. And it is strictly superficial, whereas here it could be deep perivascular and periappendageal infiltrate can also be observed in the drug-induced lichen planus. Pigmentation, like clinically we are seeing that it is very difficult to heal, pigmentation is going to be very difficult to be treated. So, the reason is because the pigment incontinence is going to be very deep, it is going to be present in the dermis. So, dermal melanopatches can be seen. And the medications, the ACE inhibitors, beta blockers, statins and NSAIDs, these could be associated with one very interesting type of lichenoid dermatitis, which is called as giant cell lichenoid dermatitis, which is also called as lichenoid granulomatous dermatitis, in which along with the lymphocytic infiltrate we can also identify the presence of multinucleated giant cells and also the histiocytes, especially associated with these medications. And how can you give the causal association, causality, this is also very important. So, drug timeline, so note down when was this medication started, when the lesions have started, so what is the latency of the medication starting, initiation and the onset of the lesions, this has to be noted down. And we can use this Naranjo probability scale, WHO UMC causality assessment criteria to ascertain and to give this medication the causal role for the Lichenoid drug eruptions. And also gold standard is the oral drug provocation or re-challenge, but this is not done in the clinical practice because this may lead to severe flare-ups in the patient. So, obviously we are not going to do this. Patch testing could also be done if it is topical agent or even a systemic agent if it is available in the patch test. How can you manage these patients? So, what is the management protocol? Obviously, step number 1 is going to be the drug discontinuation. We have to identify and stop the suspected culprit drug. and we have to also give the counseling to the patient. Like I have told you that even after stopping this medication, the lesions could persist and even new lesions could also develop, and it could take up to several weeks to even months to clear the lesions. Topically, superpotent corticosteroids could be used, which are going to suppress the cytotoxic T infiltrate, and also it will reduce the intense pruritus. Even topical calcineurin inhibitors, tacrolimus, could also be used, right? And systemic therapy in the form of oral antihistamines and even oral steroids, prednisolone, can also be used in the treatment, and also phototherapy, NBOB or POA therapy can also be used if the patient is having widespread Lichenoid drug eruption, because it will control the dermal inflammation, also it will accelerate the clearing of the skin lesions. Some special scenarios, for example, the patient is having some malignancy for which the anti-PD-1 therapy is started, definitely we cannot stop this medication. So, we have to continue this, and we should manage the patient's itching with topical steroids. And if the conditions, the skin lesions are becoming severe, then we can use drug holidays and also systemic steroids if it is very severe and recalcitrant LD. Discontinuation is going to be a problematic, so we cannot do that. So that's why we are using this modality, and that's it, dear students. If you have any doubts, you can ask in the comment section. If you enjoyed this, please hit that like button. Also do hype this video. Thank you so much. If you are not yet subscribed, please do subscribe for more such videos on a regular basis. Thank you so much. Happy learning. We'll meet again in the next video soon.